This is a continuation of our discussion of smoking cessation, and this is part 2. In this part, we're going to look at the conceptual models of smoking cessation. One of the algorithms for treating tobacco use, when you look at this particular model, is to look at an overall tobacco use treatment regime, which includes looking at relapse models. But the personal one, so this is that one, that you have a general population presenting to a clinic, and down the center of this you see the mainstay of personal tobacco use and dependence treatment, which are called the 5 A's, which we're going to look at in a little moment. But this one actually includes some attention to relapse and how to treat relapse. The 5 A's, which is what I care that you know about, is for treating tobacco as a disease, begins with asking the patient, do you currently use tobacco? And if the answer is yes, advising to quit, assessing their willingness to quit, assisting them with tobacco dependence treatment versus intervening to improve motivation to quit, and arranging follow-up. But notice if you go down the side of this algorithm on the right-hand side, if the answer is no, even though they're not currently smoking, if they were ever a smoker, there is still things to do with regards to ongoing assessment and assistance and support. Every contact that we have with a client, it should be about asking about recent or distant tobacco use. All of our contacts should include advising them to quit. All of our contacts with them should be include assessing a willingness to make a quit attempt, and in some capacity trying to assist with a quit attempt. And it doesn't help to do a one-time visit. It's necessary to arrange follow-up, so it's ongoing. So there's non-stop social support from the healthcare profession to assist with quitting. So for the patient who's willing to quit, here's a sample of a recommendation for chart use, so that you can see as a part of vital signs it's been included that, and they're trying to give it this attention and this concentration that we would ask at every patient contact if they've ever been a tobacco user, whether it's current, former, or never. The language that we use to encourage tobacco smokers to quit needs to be clear and strong and personal. It's really important that you quit. Please ask your clinician. Continuing to smoke will make your asthma worse. There's something that's personalized to your actual client and what would be the best motivator for them. Are you willing to give it a try as a sample statement or question for assessing a tobacco user's willingness to make a quit attempt at the time you're having contact with them? We're interested in having them have a finite and date and a plan to quit, so here's language that you should be able to recognize from our Prochaska model about beginning to take action. We want to recommend the use of approved medication except in the populations of pregnant women, people who are smokeless tobacco users, those designated as light smokers, and adolescents. We also want to try to provide practical counseling to them. And when I'm looking at this, I think the thing that triggered up at me versus some of the other information I think you might know is that because we know that alcohol is associated with relapse, the patient should consider limiting or abstaining alcohol as well during the time they're trying to abstain from smoking. We want to arrange for follow-up contacts either through the phone or in person. I think it would be interesting if we implemented this in our hospital programs, if we know that JCAHO is now mandating that all hospitals develop and implement smoking cessation, and I'm sure most of them have not. I know that firsthand from some experiences that students have had in leadership in which they worked in nursing education, and the decision was made to get rid of smoking cessation support groups because they weren't cost effective. It would be kind of interesting if we could take all of this information that we see on these slides I left them in there to maximally educate you, although I'm only looking for you to know and what I'm emphasizing here in red. It would be interesting if we could, as a group, go into a hospital setting in 394 and implement smoking cessation programs. Let's look at the patient who is unwilling to quit, who is a pre-contemplator, if you will. One of the things, here's some of the strategies for motivational interviewing. So one thing we can do is express empathy. We can use open-ended questions to explore. Do you think it's important to quit smoking? And try to use reflective listening. So you do think that smoking helps you maintain your weight and summarize their feelings. What I've heard you say is that smoking is something that you do enjoy and you're not willing to consider it right now. If we can note discrepancies and highlight those between their present behavior and values and goals, it might be helpful. Sounds like you're very devoted to your family. How do you think smoking affects your children? I like this one best. This is probably the one I would ask on a test, to be honest with you, because I think this is what we'll run into in pre-contemplation. And that is the resistant patient. So this describes how to, quote-unquote, roll with resistance, and I really like that particular concept and phrase. Sounds like you're feeling pressured about your smoking, so you're going to back off, but just provide information. We already know about self-efficacy and the need to help patients identify and build on their past success. So you were successful the last time you tried to quit. For each patient, we should try to help them connect the dots to understand why it would be relevant for them to quit, whether it's an asthmatic child in the house or an existing disease they have. And then hopefully the literature and information we provide has a description of the risks for them, both acute and long-term and environmental. We can also look at what are called the 5 R's, the rewards. Some things that will be beneficial about quitting smoking is your overall health will be better, food will taste better, you'll have an increased sense of smell. There's the money you won't be spending on that, and you'll feel better about yourself. So you can see on here some examples of some of the positive benefits if you've never been a smoker. And then here's an identification of the actual roadblocks that people identify as hurdles. So having withdrawal systems, fear of failing, weight gain, which is real, lack of support, depression, enjoyment of tobacco, being around other tobacco users, and limited knowledge of what's actually out there to help them. This 5 R's should be repeated each contact that we have with a client, in which we're hoping to have them move into a contemplatory phase and consider actually quitting smoking.